Okay, thank you, Anna. So earlier today, we talked about eye health and how we can't really achieve UHC without integrating eye health. And right now, we're going to talk about we can't really achieve eye health without thinking about the gender disparities. So I'd like to welcome to this stage Jennifer Gersbeck, who's Executive Director of Global Advocacy for the Fred Hollows Foundation, and Sabina Faiz Rashid, who is the Professor and Mushtaque Chowdhury Chair in Health and Poverty at BRAC James P. Grant School of Public Health, BRAC University in Dhaka, Bangladesh. Thank you both for joining us today. So globally, there is at least 2.2 billion people that have a vision impairment, with more than 1 million living with a condition that could have been prevented or treated. And estimates are that by 2050, at least 1.7 billion people will be living with avoidable vision impairment or blindness. Women and girls account for 55% of all people who have vision impairment or blindness. Fred Hollows Foundation works in 25 countries, really around the world, looking to strengthen health systems and particularly focusing on this often overlooked group within the healthcare system. So first I want to ask you, why is there such this gender disparity in this aspect of healthcare?
Thanks, Kate. Well, I think the short answer really is a lack of equal access to eye care. So even when services do exist, women face multiple barriers to accessing those services. I mean, transport can be an issue for many women in many places. And of course, with their household responsibilities, it's often difficult for them to get to services during the times that they're open. But the real barrier is the deep-seated power imbalances, the lack of economic empowerment, freedom of movement, access to information, and lack of decision-making power within the home and the community. On the flip side, health services, rarely are designed for women. Their needs and responsibilities just aren't taken into consideration. And this failure really lasts through an entire lifetime of a woman. I mean, girls who with low vision are often denied an education. And it's usually girls that are pulled out of school to look after a family member who may be living with blindness. And at work, a woman's eyes are also vulnerable in the manufacturing and agriculture sectors, where we know huge numbers of women contribute to economic development. Eye health is one of the top 5 issues of concern for those women. And with our rapidly aging population, that has the face of a woman, and rarely are older women's voices heard, and services routinely ignore both the needs and also the contribution that older women make. I think the fact is that women with vision loss are some of the poorest and most marginalised people in the world.
And I want to talk about some of the barriers you face in trying to address this. And we've been talking about integrated primary healthcare, but eye health is often not even part of primary healthcare. It's treated as a separate discipline.
Yeah.
So can you talk about some of the barriers you're facing and ways that you're trying to overcome them?
Yeah, I think the main obstacle to progress in this area is gender-related barriers to access, as I've already mentioned about access. I mean, for example, women who are blind or vision impaired can often face stigma and discrimination from healthcare providers, potentially substandard care, and definitely challenges with confidentiality. And this is made worse by system-level factors like health services that don't take into consideration the needs and responsibilities of women. In health services, you have long waiting times. And so this really adversely affects women with their household responsibilities, as I've mentioned. There's also a lack of accessible washrooms, privacy screens, maybe safe spaces for breastfeeding. And I guess to overcome this obstacle, what we need is educating these health professionals to understand how to care for people who are blind or vision impaired, and also rethinking the design of health facilities so they best respond to women's needs. Women's literacy is also lower than men's, and particularly for older people. And so women rarely get access to the information around vision loss and definitely don't know about the possibility of treatment or where to get that treatment. The lack of disaggregated data is also a real obstacle in this space. I mean, without the data, policymakers and health authorities, they cannot develop strategies to address gender inequality or to track the progress towards equitable eye care. I think it's really important that we remember that access to healthcare is a basic human right, and it's a right of every woman everywhere.
Yeah, and when we think about healthcare and some of the inequality in women, this quote a WHO report that delivered by women, led by men, which is probably a quote that could be used for many other things, unfortunately. But about 70% of the global health workforce are women, yet only 25% of leadership are men. So maybe it's no wonder that we see these systems not reflect that reality. What do you think would be the positive impacts of flipping that, and what we could do to address kind of this inequity in our leadership that could trickle down to better care for women?
So, well, one, it's a pleasure to be here. I think it's very important to understand that if I look at a specific example, which is a huge workforce that is the bridge to communities, we're looking at community health workers, and many around the world remain underpaid or not paid at all. But they're actually the anchor. They have trust with the communities. They understand the community's needs. They reach out to women. They're helping bridge sort of MNCH care, ANC care, basic illnesses, even childcare. So what we have is a absence or recognition of women because, one, we have a hierarchy around how we understand leadership, right? Status, privilege, and money. So you have many, many community health workers, mainly women, who are either very low paid or not paid at all, but their workload is extremely heavy. Secondly, you have a domino effect. What Jennifer was just talking about, quality of care. If you are overloaded, underpaid, overworked, you don't get enough training, there's high sort of turnover, low retention, how do you improve training or sensitizing them to better care for women, for men suffering from sort of eye impairments? So you have this sort of domino effect, and I think it's critical, and it's not rocket science, it's common sense, that we really need to look at this, really dismantle the top-down approaches, unpack these taken for granted assumptions because they're poor women, it's okay, and they're going to do the work because they need the money. And I think some of that needs to be just either through research evidence or activism or policy or other kinds of sort of platforms need to come together. And there's quite a lot of work being done. So I'm sure
it's been a real common
forward.
theme
Yeah.
I've been hearing this week, which is great to see getting more attention. So you, Fred Hollis Foundation, along with UN Women, launched a new report, No Woman Left Behind, Closing the Gender Gap in Eye Health. Launch is a partnership that launched this week. So Sabina, you were involved in the consultation for this piece of work. Could you share some insights from that?
Okay, so I'm not going to be able to cover most of the recommendations because there are really good recommendations. But what struck me, because I teach and I do research and I work with communities, is that we really need to kind of work across sectors. So health is siloed. Now, if we don't start discussing early on in schools, in colleges, in local communities, communities are pragmatic. Diverse but pragmatic. They will understand some of the challenges, but also we need to discuss some of the social cultural barriers around wearing glasses. Why is a young woman who wears glasses unmarriageable? That's ridiculous. But if we have those conversations, then the fear, the difference, the misinformation can be addressed. So I think it's very important to bring sectors together, even if it's one or two sectors. Secondly, I think we talked about disaggregated data. I think social science research remains on the periphery of public health research. So we have lots of surveys that we need. Yes, numbers are important, but you need the human side of life, of stories, of suffering, of resilience, of coping. And if you had more social science research, looking at the diverse heterogeneous groups of women, older, younger, even poor men who are suffering from eye impairment, I think just gives you a window to how lives unfold, but also gives that human dimension. And I think it's very important to have rich narratives because when you do policies or programs, you can't just cut and paste. Context matter. Different age groups or different kinds of needs are prioritized. A pregnant woman who has different kinds of disabilities, including eye impairment, may have different needs to an adolescent girl, to an older woman. And I think it's very important that social science research it captures, and there's funding and a focus on social science research. My final point is, which I'm sure a lot of people have said this, but beyond the tokenistic community engagement, actively working with diverse communities. They should be part of our research design. I'm a researcher. I have failed miserably. I'm trying. Co-design, co-develop tools. Go back and discuss with the communities. Do some of these I think sort of strategies, approaches work. Be flexible, adapt, and then go back and keep learning, because I think we can learn from communities.
Yeah, and I think that is advice that can apply to all aspects of healthcare. Well, Jennifer, Sabina, thank you so much for sharing your insights with us today. Thank you to the Fred Hollis Foundation for partnering with us at Devex and helping us to shed light on what is an often neglected part of healthcare. So thank you both.
Thank you.